name is Dr. Jason Chin. I'm a medical officer with the National Cancer Society and CSM, currently pursuing my master's in public health with It's my great privilege to be your moderator this afternoon. So today we're having our SKD series, was named on behalf of our founder, Dr. S.K. Dharmalingam, the first oncologist in Malaysia. And this CME, today we're talking about ovarian carcinoma. Just to let you know, NCSM is an NGO, non-profit, right? We've been around since 1966 until now. If you have any questions, please feel free to leave a comment in the Docquity app. And the Q&A session will be at the end of this session. It will last about 30 minutes or so. Right? Any questions asked throughout the CME will be addressed during this Q&A. Right? So it's my privilege now to introduce our speaker. Dr. Anuradha Suberamaniam is a Malaysian obstetrician and gynecologist with extensive qualifications and experience. She graduated from AIMS University, Kedah in 2007, completed her postgraduate studies at the Royal College of Obstetricians and Gynecologists RCOG in London 2015. Dr. Anuradha has worked with various hospitals including Hospital Serdang, Klang, before specializing in gynecology oncology through her fellowship training. She is currently a gynecologist at Hospital Tengku Ampuan Rahimah, Klang, and serves as a visiting consultant at Beacon Hospital. An advocate for women's health, she also contributes to medical education examination as an internal examiner for MRCOG Part 3. Dr. Anuradha's dedication earned her the Anugerah Perkhidmatan Cemerlang Award in 2013. So without further ado, Dr. Anuradha will give us a talk about ovarian cancer, an overview, the management, as well as prognosis. Without further ado, Dr. Anuradha Suberamaniam, take it away.
Hi, Jason. Thank you very much for the kind introduction. So I will share the slide. So this topic is very well suited for this month, actually, Jason, because this month is actually a gynecological cancer awareness month and is also ovarian cancer awareness month. So thank you very much for the opportunity given to talk about this topic. So I hope you all are not feeling sleepy after lunch. So unmasking the silent killer, ovarian cancer. Now, going a bit on statistics. So this is a data from our Malaysian National Cancer Registry. So the latest data we have is from 2012 to 2016. Okay, if you could see, for female cancer, the most commonest is still breast cancer. And then number 2 is colorectal cancer. Number 3 is cervical cancer. And then lung cancer, and followed by ovarian cancer. So ovarian cancer is the 5th commonest female cancer in our Malaysian women. Now, if you could see the data here, actually it's quite scary for me because why? If you could see over the years, the cancer deaths are increasing. Even though we have more medical awareness, more advance in medication or drugs, but still the cancer deaths are increasing for women in Malaysia. And the purple one is medically certified cancer death, and the pink one are non-medically certified cancer death. Maybe there is the pink one is the suspected cancer who don't have a tissue diagnosis. Now, if you could see the lifetime risk for females, it's about 1 in 167 for all females. And for Malays, it's 1 in 160. For Chinese, about 1 in 169. And for Indians, about 1 in 164. But if you could see over the years, what remains same is the presentation or the diagnosis of stage 3 and stage 4 cancer still remain more than 50%. So that is why ovarian cancer is known as the deadliest gynae cancer, actually, because the deaths mortality is very high if you compare it to uterine cancer or cervical cancer. Now, going into types of ovarian tumor, the types of ovarian tumor is divided into 3 according to the anatomy of the ovary. So it could originate from epithelial cell tumors, or germ cell tumors, or stromal cell tumors. So these 3 types of ovarian tumors can be divided into benign and malignant. Now I've displayed here the malignant types of ovarian tumors. Okay, so the epithelial is the serous, So the epithelial type are the serous, endometrioid, clear cell, and mucinous. And the sex cord stromal, commonest are granulosa cell tumor is the commonest, and followed by Sertoli Leydig cell, sex cord tumor, Sertoli cell, and fibrosarcoma. And germ cell tumors are more common in young patients or reproductive age group. Yeah. So my youngest germ cell ovarian cancer patient, she was 13 years old. Okay. So there are dysgerminoma, immature teratoma, yolk sac, mixed germ cell, pure embryonal carcinoma, non-gestational choriocarcinoma, and pure polyembryoma. Now, what are the risk factors for ovarian cancer? I think number one risk factor for ovarian cancer is family history. So strong family history of cancer. So you have to know your background history of cancer in the family. First generation, second generation, you have to be aware. And that's why doctors also have to clock properly what are the family history of cancer. So what are the related family history which could be hereditary is breast, ovarian, uterine, and colon cancer. And of course, increasing age. Increasing age is as well a risk factor. And postmenopausal lady is also an increased risk factor. Now, the hormone therapy is only for prolonged use of estrogen only. Yeah? So that means you still have uterus and ovaries, but you only use estrogen only hormone therapy. Then it's an increased risk. But if you use the combine of estrogen and progesterone hormone therapy, there is no increased risk. And being nulliparity, obesity is always correlated with cancer. And smoking, some data shows smoking correlated with the increased risk of particularly mucinous ovarian cancer. Now, endometriosis. Endometriosis is also a risk factor to develop ovarian cancer. It's about 2% risk. And the most common HPE type you see is endometrioid and clear cell cancer. And I have got a few instances where patients have done TAPSO, have removed their uterus, have removed their ovary for endometriosis. After a few years, patient developed pelvic tumor, and we did a surgery, and it's confirmed as endometrioid cancer. And with the precursor endometriosis was noted in the specimen. So I already have like 2 or 3 cases where previously confirmed endometriosis and then currently having ovarian cancer. Now, going into the risk factor that I mentioned, family history. So why I was talking about family history is about BRCA germline mutation. So BRCA germline mutation is an autosomal dominant inheritance. Okay, so only one parent have to carry the mutation, and 50% of your offspring can carry the gene. So we all know BRCA, you have risk factor to get ovarian cancer and breast cancer. Now, there are 2 types of BRCA. There's BRCA1 and BRCA2. So for BRCA1, for the risk of breast cancer is about 50 to 65%. Of course, males also can have breast cancer, about 1.2% risk. And those who carries a BRCA gene mutation also has risk of pancreas cancer. And of course, ovarian cancer for BRCA1, about 40 to 65%. And prostate cancer, about 9%. And for BRCA2, about 40 to 55% for breast cancer. And for ovarian cancer, about 15% to 25%. So you must remember, BRCA gene mutation, not only female have to worry, male also have to worry if you think there's a hereditary in your family. Now, the BRCA mutation is divided into germline and somatic mutation. Okay, what I'm trying to say is germline means it carries and the family is a hereditary. Okay, but somatic mutation is an acquired in any part during your lifetime. Okay, so germline mutation, the entire organism carries mutation and half of gametes carry the mutation. However, somatic mutation, it can happen during your fetal development or any part during your lifetime. And the mutation is only in the affected area and none of the gametes carry the mutation. Okay. Now, another hereditary that you have to changes to your DNA. The specific organs and risk for cancer depend on which gene has mutation in your body. Okay, so there are few genes which is associated with Lynch syndrome. So it is also an autosomal dominant inheritance. So the most common cancers in Lynch syndrome are colorectal, stomach cancer, pancreas, urinary tract, and ovarian and uterine cancer. The other less common is also brain cancer. Now, your lifetime risk for those who have Lynch syndrome. So you could see the dark blue is the general population and the light blue is the woman with Lynch syndrome. You could see the incidence of ovarian cancer, uterine cancer, and colon cancer in women with Lynch syndrome. It's quite significantly higher, the incidence rate. Now, there are a few hypotheses about how ovarian cancer develops. Okay, one of it is because of repetition of ovulation. One of the hypotheses believed that means aberrant repair process of the surface epithelium after frequent ovulation, and repeated ovulation stimulates formation of invagination and inclusion cysts. So this is believed to be the cause of ovarian cancer origin. So that's why if you could see who are decreased risk or reduced risk for ovarian cancer are patients who take oral contraceptive pill, multiparous woman, or breastfeeding woman. Why? Because all these three women have there will be no ovulation happening, because of the OCP, because every time you get pregnant and you're breastfeeding, there'll be less frequent ovulation. So that's why this group of women have reduced risk for ovarian cancer. So next slide. Yeah. The other theory is about the origin of ovarian cancer is from the fallopian tube. So there is enough evidence, actually, molecular evidence supports the relationship between tubal pathology, which is called a serous tubal intraepithelial carcinoma, and invasive serous carcinoma. So if you could see, they believe that at the femoral end of the fallopian tube, where the P53 gene mutation occurs, and it causes a serous tubal intraepithelial carcinoma, which is a pre-cancer lesion. Yeah. So, and that's what, and then it passes through to the surface of the ovarian epithelium and causing invasive serous carcinoma. This is the other theory of origin of the ovarian cancer. Now, ovarian cancer can be classified into two types, type 1 and type 2. Okay, so type 1 has a precursor lesion like ovarian cyst, endometriosis, and usually it's a good type of cancer, like well differentiated cancer. And common HPE type is endometrioid or clear cell, and commonly can be diagnosed early, stage 1, stage 2, and the prognosis is favorable. Yeah, but if you see the type 2 ovarian cancer, the precursor lesion is from the distal fallopian tube or from the ovarian surface epithelium. And they are most usually a high-grade tumor or poorly differentiated. And the most common is high-grade serous ovarian carcinoma. And they are usually diagnosed at late stage 3 or 4. And the prognosis is usually very poor, not favorable. And they always have a P53 overexpression. And they are commonly associated with BRCA1 or 2 mutation. And will have genomic instability. Now, because we know, and there's enough evidence to say that one of the cause of origin from ovarian cancer is from a tubal pathology. So that's why if you do opportunistic self-injectomy during hysterectomy and tubal ligation, you reduces the risk of ovarian cancer by 42 to 65%. So this has proven. So that means if the patient is going for hysterectomy, and patient is young, 40, and patient would love to keep the ovaries behind, then you should do hysterectomy together with self-injectomy. And if the patient requests for tubal ligation, I think we should consider self-injectomy, to reduce the risk of ovarian cancer for the patient. However, if the patient, I think when you counsel the patient for hysterectomy, it's about, basically it's all about counseling. Whether retaining the ovaries or removing the ovaries, it should be the patient's choice. Where if the patient is more than 40 years old, have completed family, and they have no issues, so actually they could remove the ovary as well, because this reduces the risk of ovarian cancer in the future. Because I have come across many patients who have done hysterectomy, but ovaries have not removed. And after 10 years or 20 years, they come with cancer to me. Yeah. Now, the Angelina effect is the famous effect. Okay. So Angelina Jolie have created very wide awareness regarding BRCA gene mutation with her risk reduction surgery. She carries BRCA1 gene mutation. So she has done bilateral mastectomy and also self-injectomy, self-injo oophorectomy. Yeah? So because her mother and grandmother and her auntie has cancers. So risk reduction self-injo oophorectomy in a patient who confirm BRCA gene mutation carriers reduces their risk of ovarian cancer by 80 to 90%. And also reduces the risk of breast cancer by 50%. However, a small lifetime risk of primary peritoneal cancer still persists after risk-reducing bilateral self-injo oophorectomy. Usually, if the woman has been diagnosed with breast cancer, or her family has a strong family history of breast cancer, ovarian cancer, or you think Lynch syndrome, so they are advised to take genetic testing actually. So if the genetic testing confirm you are BRCA gene carrier, gene mutation carrier, so we will usually monitor. So we will do very early screening from the age of 25 itself. So if you are more than age 35, then you can consider a risk reduction self-injo oophorectomy if you have completed family. Now, what are the symptoms for ovarian cancer? Actually, the problem is in early stage ovarian cancer, it's very mild symptoms, or sometimes it's no symptoms until patient have come in advanced stage. So what are the possible early stage symptoms like frequent urination, always feeling bloatedness, early satiety, feeling full quickly when eating, or pelvic pain? So sometimes you see this bloatedness can be disregarded or can be symptom of other problems as well. So when it become advanced stage or the tumor have become very big, then only patients start feeling some symptoms. What they can have is altered bowel habits, where they alternate with diarrhea and constipation. They can have some fluid collection, meaning ascites, pleural effusion. So many patients have come presented with shortness of breath, tachypnea to ED. Then they find out the patient have ascites, gross ascites, pleural effusion. That's when we end up diagnosing ovarian cancer. Yeah. And many patients, my patients mostly come with a very huge mass per abdomen actually. And when I ask her, didn't you feel that your tummy is increasing in size and all that? They always say, oh, saya ingatkan saya sudah gemuk. I put on weight. I thought I put on weight, you know. So many women actually, they walk in to see me where they look like they're pregnant actually, because the tumor is so huge. They keep it so long. Now, screening for ovarian cancer. There is no early detection tool for ovarian cancer. But if you have high risk family history or you have germline mutation, you are recommended to do annual CA125 and pelvic ultrasound. Okay. There are 3 large randomized trials on ovarian cancer screening, okay, in US and UK. So the US recommends against ovarian cancer screening in a low risk woman. And in UK, they inconclusive, they not clear, there's no clear definitely saves lives, but they want to do further follow-up before they conclude. So still there's no appropriate screening available for ovarian cancer actually. Even I have seen, I have followed up patient with a BRCA gene mutation with CA125 and pelvic ultrasound, where I see them 3 months or 6 months ago, they are fine, but after 3 months or 6 months, suddenly they develop ovarian cancer. So even with the annual screening, you still may not detect the ovarian cancer early actually. So now tumor marker, going into tumor marker. So CA125 is the common tumor marker used for ovarian cancer. However, there is limitation for CA125 because only 50% of stage 1 disease will have raised CA125. And CA125 also can be raised in other cancers, such as cervix, uterine, breast, liver, and pancreas cancer. And CA125 also can be raised in benign conditions, like pelvic inflammatory disease, endometriosis, menstruation, anything that causes peritoneal inflammation, cirrhosis, pancreatitis, all can cause raised CA125. So it's very non-specific sometimes, but when it's raised, it at least gives us to be more alert to look for what is wrong. Now, this HE4 tumor marker has been there for quite some time, the human epididymis protein. But however, the recent studies promising as accurate predictor for only recurrent ovarian cancer, not for diagnosis of ovarian cancer, early ovarian cancer. But however, it is still not recommended by any international guidelines, and it is very expensive. It's almost 1,000 plus, this test. Now, what are the tumor markers that we screen or look for in a cases patient with ovarian tumors? So if you think you suspect germ cell tumor or the patient is in the younger age group or reproductive group, so you should take alpha fetoprotein, beta HCG, and LDH together with CA125. Yeah, because alpha fetoprotein is commonly raised in yolk sac tumor and immature teratoma. Whereas in beta HCG is choriocarcinoma, embryonal carcinoma, rarely dysgerminoma. And LDH will be raised in dysgerminoma. So if you see a young patient, looks like germ cell, but you don't know benign or malignant, so these markers will give you a guideline actually. Because a patient with cancers, well, whoever I see in my cases, the alpha fetoprotein and LDH will be raised very high in a cancer patient. Now, CA125, of course, an epithelial tumors, and CA99 is commonly raised in mucinous ovarian tumor. Now, what are the predictive capability for ovarian cancer? So, risk of malignancy index, RMI, have been used for many years now. It's still been used, okay? So, the RMI includes the ultrasound features, serum CA125 level, and the menopausal status of the woman to characterize the ovarian pathology. Actually, this risk malignancy index will guide you whether who should do the surgery, who's the appropriate center that you should refer to, okay? So if your RMI is more than 200, it should be referred to center experienced with ovarian cancer. Now, so this is the RMI criteria. So one of the it involves 3 criteria. One of it is looking at the menopausal status, whether premenopausal or postmenopausal, and the ultrasound features, whether there are multiloculated areas, solid areas, is it bilateral tumor, evidence of ascites or metastasis, and the serum CA125. So you score this, all these three features. Now, there are other risk assessment tools out there, okay, also known as International Ovarian Tumor Analysis, IOTA. So it follows a simple rules where there is some data says that it's performed better than the RMI actually. So the first one that was developed was the simple rules, where it developed in year 2008 for a preoperative classification system for ovarian tumors, where they divide into, is it B features for benign tumors or M features malignant tumors. So based on which B features or M features, the tumor can be classified as benign, malignant, or inconclusive. So benign is only B features, malignant is only M features, and it's inconclusive. So they come up with the conclusion. And so this is what they look for the benign features. Benign features are unilocular, presence of solid component less than 7 mm, yeah, presence of acoustic shadows, smooth multilocular tumor, less than 10 cm, no blood flow in your color Doppler from your ultrasound. In malignant features are irregular solid tumor, presence of ascites, and tumor largest more than 10 cm and very strong blood flow. So these are the malignant features. So if you don't have any malignant features, there's only benign features, so the risk of malignancy is low. Then the IOTA came out with the simple rules risk calculator. They came up with a calculator for scoring called the IOTA at Next. It is a web application. It's also in the phone app, but however, currently it is not available. So this is how the web application will look like, where they'll put in the values here, the predictor values here, and then the web will calculate your risk of malignancy. So for like in this case, the risk of malignancy is 90%, and the chance of benign tumor is only 9%. So currently, this app is suspended awaiting certification due to change in regulation. So this is how the phone app will look like for the IOTA at Next. The other risk of ovarian malignancy algorithm called ROMA. So this is also an app where they score, where they take HE4 level and CA125 level and menopausal status, and they put it in this app to calculate your risk. So this is not available in Malaysia. It's not available in Android also. The other risk assessment tool available is the OVA1 test. It is just a blood uses a blood sample test. Then it takes 5 proteins to get numerical score. However, it has high false positive tests. Now, going into management. So ovarian cancer can only be confirmed by cytology, tissue biopsy, or surgery. So cytology meaning if patient has gross ascites, you can do a peritoneal tapping and look for peritoneal cytology, or pleural cytology. So we will do an immunohistochemistry to look for which one is the primary. So we look at CK7 positive, then its primary is gynae pathology. And ovarian cancer is staged surgico-pathologically with imaging information. It can be CT scan or PET scan. Now, in young patient, we can do fertility sparing surgery as long the patient understands. Actually, certain HPE type, we can do fertility sparing surgery, especially the germ cell tumor, because the germ cell tumor are very chemosensitive. So as long the patient understands the risk of recurrence, risk of another surgery or multiple surgery is there, and the morbidity is high. So for a young patient, you can opt for fertility sparing surgery. And for a patient who are okay with the completion surgery, so the upfront surgery, primary cytoreductive surgery, we do primary cytoreductive surgery if optimal debulking is feasible. That means the surgeon, the gynae onco, will assess, looking at the imaging and assess the patient as a whole and whether it is operable. That means all the tumors can be removed then a primary cytoreductive surgery will be done. So otherwise, interval debulking surgery can be done after neoadjuvant chemotherapy if upfront surgery is not feasible or patient is not fit for surgery. So sometimes because of cancer, patient are more prone for thrombosis. So my patient will come with a massive pulmonary embolism, massive DVT. So patients like that who are not fit for surgery will do a interval debulking surgery after neoadjuvant chemo. And the staging laparotomy, skin incision must always be midline. So these are the patient if you suspect ovarian cancer, okay? Complete evaluation of all visceral and parietal surface in peritoneal cavity. And the peritoneal fluid or washout for cytology must be taken at least minimum of 100 mils. And our aim during the surgery would be to remove the tumor intact. Yeah. And omentectomy, it is part of the staging, must do omentectomy. And we will do a random peritoneal biopsy as part of the staging. So pelvic and para-aortic lymph node dissection in apparent early stage, or if the CT scan image or PET scan shows there is some enlargement of the pelvic and para-aortic, so you have to do lymph node dissection as part of the staging. Now, these are some of the pictures from my surgeries. So if you could see this, this is mucinous ascites. So this is the case of ovarian mucinous tumor. But however, this is the case of a pseudomyxoma peritonei, which is a rare mucinous disease, which is the primary is the appendix. So that's why, so we will consider to remove appendix in most of the cases with ovarian tumor. So this is one huge tumor. And if you could see this, this is a case of low-grade ovarian serous. This is how a low-grade serous look like. And this patient have done hysterectomy. So there's no uterus here. So, but the ovaries were retained. So this is patient developed cancer, ovarian cancer. And this is the patient, a young patient with a germ cell tumor. I've been seeing more younger and younger patients are getting ovarian cancer. More acquired, most probably it's acquired genetic mutation, I believe. It could be due to food, environment. I believe all this has a factor why more younger patients are getting cancer. So as I said before, my youngest patient is 13 years old, then 17 years old, 18 years old. Now, this is how omental nodule, you can see it's a huge omental nodule here. Okay, omental caking means this whole omentum, you won't see a normal omentum, where it looks like a sliced hardened cake like that. That's why we call it omental caking. So this is how it looks like after a lymph node dissection. So this is the aorta, this is the IVC. What is tagged here is the ureter. This is the ureter is being tagged. So this is the common iliac artery. This is the external iliac artery, internal iliac artery. This is the psoas muscle. So this is how it looks like after a pelvic lymph node and a para-aortic lymph node dissection looks like. Now, going into FIGO staging, there's now been changes for the last few years, still remaining the FIGO staging 2014. Okay, so you could see the tumor from 1C is divided into 1C1, 1C2, 1C3. Stage 2, pelvic extension. Stage 3 to upper abdomen, microscopic or macroscopic. Stage 4 is the distant metastasis to the pleural effusion with positive cytology, or liver or spleen parenchymal metastasis. Or others are like inguinal lymph nodes or lymph nodes outside the abdominal cavity. Now, the treatment for ovarian cancer. Surgery is the mainstay of treatment for all stages of ovarian cancer. So, patient with stage 1A, 1B, and well-differentiated tumor does not need adjuvant chemotherapy. Okay, so other than this group of patients, they all need a chemotherapy. Even if they are 1A, but they are poorly differentiated tumor, a 1A or 1B, poorly differentiated tumor, they still need adjuvant chemotherapy. So what chemotherapy we usually give is a combination of carboplatin and paclitaxel. That is the standard of care. And for germ cell tumor, it's a different type of chemo. It's a bleomycin, etoposide, and cisplatin. Now, how about prognosis? The 5-year survival for invasive ovarian cancer. Now, for invasive ovarian cancer, if it's diagnosed as stage 3 and stage 4, it is poor prognosis. As you could see, for stage 4, 5-year survival is only 17%. And stage 3 is almost 30 to 40% actually for invasive ovarian, epithelial ovarian cancer. Now, what are other treatment available other than chemotherapy? So there are targeted therapy available for ovarian cancer treatment, which is called bevacizumab. It is an anti-angiogenesis. It's been there for a few years now. The company developed is the Avastin. Okay, so what does bevacizumab, which is an anti-angiogenesis, causes is? So it is believed that the vascular endothelial growth factor that stimulates the growth of new blood vessels. So it feeds the tumor. If you could see, there's always a feeding vessel around the tumor. Yeah. So what Avastin does is, so Avastin blocks the VEGF. So blocks the VEGF. So it will not cause new angiogenesis will not happen. So Avastin block the tumor's ability to communicate with the nearby blood vessel and prevent the tumor from connecting to the blood vessel. And there's another company, actually, the problem with in the government side is the targeted therapies are very expensive. They are costly. So most of my patients can't afford targeted therapy. If you see like this bevacizumab, it is just one time you're giving patient is 7,000 ringgit. Yeah. So it has to be given every 3 weekly or 4 weekly with the maintenance of 1 to 2 days. So most of my patients can't afford targeted therapy. Now, bevacizumab, the targeted therapy is only used in advanced ovarian cancer or recurrent ovarian cancer. But the ICON-7 trial showed that it only extended the progression-free survival by median of 2.4 months only. And the other trial improved the median progression-free survival by about 4 months in women. So I would say it is a costly drug with a modest progression-free survival. Now, what other targeted therapy available is PARP inhibitor. So it is a poly-ADP ribose polymerase. So the PARP inhibitor have showing a very promising outcome actually. So the newest generation of drugs has dramatically increased survival for advanced ovarian cancer. So the progression-free survival with treatment has improved by 60% compared to without treatment. Yeah. So progression-free survival are even up to 4 years with the treatment of PARP inhibitor. So how PARP inhibitor works? It is when the chemotherapy, usually PARP inhibitor is followed after a few cycles of chemotherapy. So the chemotherapy inflicts a DNA damage. So, and this PARP inhibitor will inhibit the PARP. So it disables the DNA to repair. So that means this is occurring inside the tumor, yeah? So it causes the cell death of the tumor. Okay. So what is out there? First what was produced is the olaparib. Okay. So olaparib has been recommended for use those who are tested for somatic germline mutation. That means when you remove the tumor, you send the tumor for molecular testing. So it has a BRCA mutation or HRD positive. HRD means homologous recombinant deficiency. Then it showed that olaparib or the PARP inhibitor has a significant improvement in the progression-free survival actually. So this is the case of which is a tumor molecular testing done HRD positive. So they recommend that you use the platinum-based chemo, add with the bevacizumab, and followed by PARP inhibitor for 2 years. So more advanced studies are still ongoing as a olaparib as a monotherapy. So olaparib has been granted as accelerated approval as monotherapy for suspected germline BRCA mutated advanced ovarian cancer. So after at least 3 prior lines of chemotherapy. Yeah. So the recommended olaparib dose is 400 mg twice daily. Now, the disadvantage, of course, the cost, the pricing of these drugs. Yeah. So olaparib, if you want to use olaparib, per month, it can cost 35,000 per month. So most of the patients can't afford in the government sector, definitely. In private sector, those who have insurance, and insurance also must have a good insurance coverage that covers cancer treatment as well. So those are the type of patient who can afford this olaparib. But olaparib have shown promising results for progression-free survival for advanced ovarian cancer. Now, this is just a summary of what are the treatments. So in 2011 was the introduction of the anti-angiogenesis, where the bevacizumab was added. We gave together with the chemotherapy and then followed by maintenance for 2 years. And then there was the introduction of PARP inhibitor in a patients with BRCA mutation. It could be somatic or germline. Yeah. So where with the chemotherapy followed by maintenance PARP inhibitor. And then in 2020, that's when it's included as for chemotherapy, add with the bevacizumab and then maintenance with the olaparib. Now, the future is monotherapy, monotherapy with the PARP inhibitor. That's how the future going. But as I said, it's a very, very costly drug. Yeah. Thank you.
Thank you so much, Dr. Anuradha, for sharing your amazing experience. Thank you for sharing the case as well. Thank you for showing the amazing pictures and sharing your experience and knowledge about ovarian carcinoma. So at this time, actually, there are a few questions coming in from our Facebook that we are looking at now, right? One of the first questions is actually from one of our doctors who's working in East Malaysia in Sabah, actually. So they're asking, in your opinion, Dr. Anuradha, we have seen the statistics from 2012, 2016, right? But what do you suspect the latest statistics will be for the next MNCR? And why do you think the reason is for that?
Yeah. Firstly, I believe the data may not be, I feel it will be underreported. Okay. Because why? Because you see, I do gynae onco work in Klang Hospital and Shalam Hospital. And the thing is, the National Cancer Registry has to be record all the new diagnoses in the National Cancer Registry. And it previously, during when I was medical officer, it was all in a hard copy, in a paper, right? In a paper. Now it's all online. Now it's all online. And only certain people in the department will have the login password to, are trained to enter this information in registry. So if the person is not keeping up and, taking and all this, because you see in the government, there's so many cases. So sometimes it is missed. Sometimes I also forget to ask, have you entered in the registry? Have you put in? Oh, no, I forgot, doctor. So it has happened. So I still believe there may be some hospitals may not be reporting accurately the data. So so I have come across that they are not reporting up to date. So I believe this is my personal opinion, it is still could be underreported. Okay. And I feel whatever data that they have now, I think it's out there is more. I feel it is more. So unless even the private hospitals and all the hospitals, even the district and tertiary hospitals, take initiative to accurately collect the data and input, then only we can have an accurate data. So that is the shortfall, I would say. What I'm seeing across from since I was a medical officer until now I'm a gynae onco, I am seeing increase in the cancer in general. Even endometrial cancer is increasing so much with more younger ladies. And I'm seeing more younger women are dying with the advance. So I believe definitely it's going to be more unless it's underreported. This is a personal opinion.
Well, thank you so much, Dr. Anuradha. I hope my colleague in Sabah can actually. I hope that answer was satisfactory for you. Dr. Anuradha, that was a good explanation for underreporting. I agree. I totally agree. Okay, so we have a question now from Dr. Lim from the DocWitty app. Hi, Dr. Anuradha. May I ask about the CA125 tumor marker? What is the level of significance that may indicate an ovarian tumor?
Okay. You see, as I mentioned before, CA125 has limitations. Yeah. So CA125 is just a guide for us. It's just a guide. So in some women may have a CA125 a bit raised during their menstruation. So if you see, if they go for a medical checkup and they go and take all the tumor markers and they go and take during their menses, so the CA125 can be raised up to 50 or 60, and then they refer to us. So it's fine. It's fine. It just causes unnecessary anxiety to patient actually. So in a low risk woman, it is not actually advised. But the CA125 has limitations. So because it can be raised in PID, it can be raised in anything that causes inflammation to the peritoneum, and it also can be raised in a benign ovarian cyst like endometriosis. Okay. And what I'm trying to say is CA125 is just like a part of a guideline for us. Okay. Because I have seen personally CA125 only 40, 50, that's minimally raised. But the HPE came back as cancer. And I have seen CA125 1,000, but the HPE came back benign. See, so it is just a guide. So CA125 with the imaging, whatever imaging you have, CT scan, and your ultrasound. So an expert who are expert and experienced in doing ultrasound for cancer patients. Yeah. So all this combined, then only you assess the risk, whether this patient is possible cancer or possible benign. But trust me, I have seen all. Nothing is 100%. Okay, because I have seen even in I opened up. I thought, oh, I'm dealing with a high grade ovarian carcinoma, but the HP came back as TB. Okay, so they had a raised CA125. The intra-op, it looked exactly like an advanced ovarian cancer, but the HPE came back as TB. So nothing is conclusive. That's all I can say. So only by surgery you can confirm whether it's cancer or not. So CA125 is just the guideline. Okay.
All right. Thank you so much, Dr. Anuradha. TB again. The TB is just everywhere at this point. Right. So we have another question actually. So this is actually given from one of our doctors, actually from Sarawak, asking us now. Regarding genetic testing, will there be issues in getting insurance for those who are BRCA testing positive?
True. So you see, insurance has been always a big problem. Firstly, I would like to advise everybody, please have good insurance coverage. Okay. Please take it as young as you can, as early as you can, and make sure you have a good insurance coverage, not 50K, 70K per year. You have to have a good insurance coverage because why? Cancer treatment is very, very expensive, and not everything is sponsored in the government. Yeah. So please make sure you take insurance early, and the coverage is good, and make sure you confirm with the agent whether it covers cancer treatment, because certain insurance doesn't cover cancer treatment. So you must make sure whether it covers the cancer treatment. That's number one. Now, number two, if you are going to do a genetic testing, do take insurance first. Okay, so you didn't hear this from me, okay? So if you know you have strong family history, of course, there's a first generation, or there's two generation involving a particular cancer, and you suspect there's a possibility of hereditary. Yes, you can do genetic testing. But if you have already taken a genetic testing and it's confirmed a gene mutation, yeah, you will not get insurance.
Well, thanks so much, Dr. Anuradha, for that good advice as well. So, insurance before you get tested. So the next one is this. So the advice, thank you for the sound advice. All right, I've got another question actually here from Dr. Norman from Kuantan. He's actually asking, would you recommend women in Malaysia to undergo the Angelina Jolie effect? Basically, BRCA positive can go for risk reduction surgery.
Okay. So there is an active program in UM where when I was attached in UM, so there was a magic study going on for a few years in Malaysia where we were doing genetic testing for either those breast cancer, those are breast cancer women. So when this breast cancer women were confirmed BRCA positive, so that means the cancer is only in one side, right breast maybe. So when they are BRCA gene mutation positive, they are counseled for remove the other side of the breast, and they will be referred to me for counseling for risk reduction oophorectomy, self-injure oophorectomy. So usually it is about the counseling. It's about the patient wish. Okay. So if they are BRCA gene mutation carrier, so usually we will counsel for risk reduction surgery once they completed family. But sometimes, unfortunately, the breast cancer starts very early. Yeah, less than 35 years old, all these BRCA gene mutation carriers starts having a breast cancer. So at least what I see is at least the ovarian cancer starts late a bit, you know. So I have been in the team where we counsel about the risk reduction in a BRCA gene mutation patients. So usually once they are 35, we start counseling. So some of them acceptable, some of them not accepting. So if the woman can accept, yes, it is safer to go for mastectomy and risk reduction self-injure oophorectomy. So I have done quite a few risk reduction self-injure oophorectomy actually. So some people question why you remove the tube and ovary only, why leaving behind the uterus? There's no function for the uterus. But you see, this is a risk reduction surgery. We only want to do minimal. We don't want to do unnecessary extra surgery unless she has, I think she also has a risk factor for uterine cancer, then yes. So it all depends on the woman and the counseling by the doctor. Okay, so if the patient refuse for all his risk reduction surgery, so she will be annually followed up. For breast, we follow up with the MRI breast and the ultrasound breast, and with the CA125 and TVS for a BRCA carrier woman. It all depends on the woman whether they want it or don't want.
Thank you, Dr. Anuradha. I think that the BRCA genetic counseling is being done with Prof. Aisha's team, I'm not mistaken.
Yes.
I've sent a few patients to her as well. With BRCA positive, like, okay, go talk to her, see what you want to do.
Yeah. I was in the same team with her. Yeah.
That's fantastic. That's amazing work. All right. So for now, there's another question actually from Dr. Ali from Kedah. He's actually asking, because he runs the GP, he's asking, what are your opinions about annual screening of CA125 for high-risk women respectively? And this will combine with ultrasound abdomen pelvis as well. Should that be done annually, or how often should it be done? Because he can't find guidelines.
Actually, the guideline only says only for high-risk patient. Yeah, only for high-risk patient. High risk like a family history, strong family history. But there are patients with strong family history, but they are not doing genetic testing, you see. So, but they have strong family history, or they have confirmed hereditary carry a hereditary cancer. So they are advised for annual CA125 and TVS. But as I said before, I have seen patients who monitor 3 monthly or 6 monthly, where now you see CA125 and TVS is normal. You see them after 6 months, it can be, so, but the guideline only says annual. For high-risk women, only annual, yeah.
Right. Thank you, Dr. Anuradha. I hope that answers your question, Dr. Ali. So basically, high-risk women with ovarian carcinoma go for CA125. Right. So actually, there's a question from Dr. Baldev, who is a GP. He was actually asking, any other tests besides CA125 that you can detect the progress of ovarian tumor? And a follow-up question, do you do HE4 testing regularly for patients?
We don't do HE4. Okay. So first of all, as I said before, HE4 has a high false positive, and no international guideline recommend HE4 actually. It's not recommended in the international guidelines, and it is very expensive. One-time test is 1,000 plus. Yeah, it's very, very expensive. So we don't do HE4. So other than CA125, no, as I said, different patient, if you think is you suspecting in a young age group, as I mentioned before, if it's a germ cell, so if the patient confirm having a germ cell ovarian tumor, so we'll follow up with the alpha fetoprotein or LDH, with combined with CA125. So it depends on the type of the ovarian tumor as well. So if it's already confirmed it's a germ cell tumor or mucinous ovarian tumor, so mucinous ovarian tumor also, we will follow up with CA99 as well. Yeah.
Thank you so much, Dr. Anuradha. I hope that answered your question, Dr. Baldev. Basically, HE4 is not tested regularly. It's not, there's no studies that recommend it yet lah. Okay. So I think we have time for one more question, and I think there's one more. In regards to the pricing of olaparib, bevacizumab, basically of targeted therapy, are there any ways patients can get access to this without paying, or rather, is there anything that's any other funds that's being helps for these patients to get access to this?
Actually, I've tried. There are patients who are government servant, you see. So we have tried with the JPA, but what they say is you pay first, then claim later. Okay. So the paying first is the problem, because at one go you're paying 7,000. But there are another generic, just newly produced now, generic for bevacizumab, which is cheaper, which is 1,700 now. Okay, but still 1,700 every month. So every month with the maintenance of 2 years. So that is for bevacizumab. The olaparib is very expensive. The PARP inhibitor is very expensive. It's almost 30 to 35K per month. It's a pill. It's a pill only. The bevacizumab is given through IV, intravenous infusion. But the olaparib is a tablet form. It's a pill that you have to take every day. So olaparib is very expensive. So there's no way, unless you have a good insurance, that can cover for that treatment so far. Unless you're taken into the study, during the study time, they were taken into the patient, recruited, and these are the lucky patients. Yeah.
Well, let's hope for more ways in the future. 4 years survival rate sounds fantastic. Olaparib. All right, I think that can conclude for our session today. So just to wrap up what Dr. Anuradha said, for those women who are high risk, annually perform an ultrasound as well as a CA125 for them. Other than that is to teach them about the risk factors, to reduce their risk factors, and also for BRCA testing after you get insurance. Okay. So thank you so much for your time, everyone. Thank you, Dr. Anuradha, for sharing your experience and your knowledge. It's been wonderful hearing from you. You're such an amazing speaker. love just hearing you speak.
Thank you.
Right. Bye, everyone. Have a good Saturday. Have a good weekend, and see you for next month. Have a good day.
Thank you. Bye-bye.